The ASCO GU this year, being virtual, we missed the action in person, but I think this time ASCO GU had very important study updates, especially in the bladder cancer space. We know that Enfortumab Vedotin, which was approved last year, was given an accelerated approval by FDA for metastatic urothelial carcinoma in patients who had progressed on chemo and immunotherapy, pending the phase 3 data, which was presented at this ASCO GU, which was very important, and it clearly showed that the drug is active and has now cemented its role in treatment of metastatic urothelial carcinoma patients. This was EV301, which was presented by Dr. Powell's. The trial enrolled 608 patients, half of which got EV versus other half got chemotherapy of physician choice. The chemotherapy drugs were primarily docetaxel, vinflurine, or paclitaxel. And after the median follow-up of around 11.1 months, the difference in the median overall survival was close to 3.9 months, with over 12.8 months median OS in the EV arm and around 8.3 in the chemotherapy arm. The benefit was seen across all subgroups of patients enrolled, with close to 40% patients having overall response rate and close to 72% patients having disease control. And, this is a patient population which has been already received chemotherapy, and many of them had received immunotherapy. And so this drug is definitely an important breakthrough for our patients in urothelial carcinoma. The drug is not benign as IO therapy, with close to 23% patients having grade 3 or higher treatment-related AEs. But I think there's a learning curve to it, and once physicians get used to using this drug in their patients, they'll get comfortable with the toxicities and managing them, and with predominant toxicities including cytopenias, rash, and fatigue. The other trial, which was very important, I think, was critical for our patients in bladder cancer. It was in the non-muscle invasive BCG unresponsive state, was the QUILT study looking at N803. This is a novel molecule, which is interleukin 15 attached to an IgG with a cytokine fusion protein. This molecule attaches to and it causes the recruitment of NK cells and CD8 T cells in the tumor milieu, and does not induce proliferation of Tregs, which technically suppress the immune response. So it's a very, very novel molecule. It was investigated in BCG unresponsive state. The trial prior to this, the phase 1, which looked at combining BCG and N803, showed that 100% patients who received the combination had a CR, and the disease was controlled up to 24 months. Based on that, the FDA gave them a green signal to proceed with a pivotal trial, of which the cohort A data was presented, and which I think is very important for this disease setting, because we saw last year pembrolizumab being approved in this space, not because of very exemplary data. 41% patients had CR on pembrolizumab at their 3 or 6 months time point evaluation, but only 18% could maintain that CR at 12 months post documentation of CR. And this pembrolizumab was approved primarily for the perceived benefit in this space because lack of any other effective drug. So clearly, this study, I think, is an important step forward. The patients who received N803 in combination with BCG in this BCG unresponsive state, 71% of the patients reported a CR at any time point on the trial, and the median duration was 19.2 months, with a cystectomy-free rate of around 88%. Is remarkable. And as compared to the pembrolizumab, However, this data is early because the pembro data had 24 months follow-up, and this trial presented an early update at a follow-up of around 10 months. But clearly, I think this is important and something we'll be watching closely as the full publication gives out full details on the trial design. It was not very clear how these CRs were measured on the trial in the abstract, but I'm going to eagerly await for the full publication to understand if what we are seeing is truly observed in our patients, and then I'm certainly sure that this will be considered seriously by FDA in this space.